Did you know 1 out of 8 men will be diagnosed with prostate cancer? Neither did I, until it happened to me. Fighting prostate cancer has taught me lessons about signs that people will miss, about the things that you will go through during treatment. Yes, male hot flashes are a real thing. The things I've shared with my friends about prostate cancer have saved lives due to early diagnosis and treatment. I made this video presentation because what I share could save yours too. 1 out of 8 men will get prostate cancer in their lifetime. For black men, that statistic is 1 out of 4. If you have prostate cancer on your paternal line, your grandfather, your father, your father's brother, so your uncle, or your brother, you have 2.5 times greater risk of prostate cancer and an increased risk of getting prostate cancer between the age of 40 and 45. If your mother or your sister had breast cancer before the age of 60, you have an increased risk for prostate cancer. In the United States, there will be about 275,000 to 315,000 men diagnosed with prostate cancer every year. Although the statistics are good for having a normal life expectancy, even with metastatic disease, still we are losing about 35,000 men per year to death by prostate cancer. My name's Joe Dooley. I'm 64 years old. I live in the north suburbs of Chicago. I have advanced stage metastatic prostate cancer. I'm here tonight because I want to talk to you about prostate cancer so that we can learn about it. My goal in this talk is that you or your loved ones will learn how to get an early diagnosis of prostate cancer, and so that you will not suffer metastatic disease. The second half of my talk, I'll talk about my journey through my prostate cancer, which metastasized, so that it will reinforce the message at the beginning that you don't want to go there. And my story is okay. Things went okay. I'm in remission right now. I've been treated and I'm in remission. And there are a lot of men that are going through far worse treatment than I went through. The end goal is to make sure that we can get diagnosed early and not get to metastatic disease. A couple things before we begin. I'm not a doctor, so anything that I say is a lay opinion or lay advice from my perspective as a prostate cancer patient. You should consult your doctor for medical advice. If you're above 75, I don't even address that in this talk because the diagnosis and treatment is a whole different ballgame for men in their late 70s and 80s, because it's usually more of a slow-growing disease in a man who has other conditions that would be more likely to take their life before prostate cancer would, and also prostatectomy might be a higher risk procedure for somebody at an older age, so that's a conversation to have with their doctor. So first, what is the prostate? I gotta say, when I first got diagnosed, I didn't know really what it was or what it did. The prostate is one of your it's your reproductive gland. It sits right under the bladder and right in front of the rectum. It has seminal vesicles are right on top of the prostate. The prostate has 2 nerves above it that are for controlling your erection. From the bladder down through the prostate runs the urethra. At the top of the prostate, there's an internal urethral sphincter, which controls the release of the urine from the bladder through the urethra. At the bottom of the prostate, there's an external urethral sphincter, which will control your release of the urine. It's a voluntary muscle so that when you need to go, you can hold it until you get to the bathroom and go. Those 2 sphincters will become important later when we talk about the prostatectomy. What is the function of the prostate? The prostate produces a seminal fluid to enrich and nourish the sperm as it comes down the reproductive tract. It has protein, minerals, and enzymes in that fluid to make sure that sperm survives through the reproductive tract to its end zone into the female vagina and of her reproductive tract. The other purpose is for controlling the urinary flow, and also there's a purpose of hormonal metabolism of the prostate. prostate cancer within the prostate and actually outside the prostate is asymptomatic. You will not know that you have prostate cancer. You can go on with your normal life, even if it metastasizes, until something horrible happens, like you have a bone fracture or you have inability to breathe, and you go into the doctor for it, and they say, "Oh, you've got cancerous tumors in your bone or in your lung." That's when it's really a bad metastasis, and it's moved without you knowing it. But when it's within the prostate, when you have that chance to get it out before it metastasizes, you won't feel it. You won't know you have it. There's one test that is used today. It's the PSA test. It's a simple blood test. PSA stands for prostate-specific antigen. It is a protein that is produced in the healthy tissue and the cancerous tissue of the prostate. And it will put out a reading into the blood, which they call your PSA blood score. You can have a rise in PSA from enlarged prostate, can cause a rise in PSA. Prostatitis, which is an inflammation of the prostate, can cause a rise in PSA. Prostatic infection can cause a rise in PSA. They also will do at your annual physical a digital rectal exam. I will tell you now that that will not be in any way diagnostic of or suspicious for prostate cancer unless they actually feel a lump or bump on the wall that they feel when they go into your rectum and push on the prostate. If they feel a bump, well, that means you have a tumor on the outside on the wall. That's very rare. The way that they're going to find it is with the PSA. One thing that I have learned in talking to men about PSA is the most that they know about PSA is they went to and had a blood draw, and their doctor told them that it was normal. But nobody knows their PSA score. Everybody seems to know their cholesterol score. Everybody seems to know, if you ask them their handicap index for golf, they know that. If you ask them what kind of car they drive and how many miles does it have on it, they can tell you their odometer reading. But they can't tell you a score of their prostate exam, the PSA, which will determine whether or not they have prostate cancer. You need to know that score. The lab values that come in usually are coming from a lab, and they say that normal is 0 to either 4.0 or 4.5. And doctors will look at that and tell their patient that you are normal at anything in that range. The truth is, you may be abnormal. I've put up a chart here from the Cleveland Clinic. There are other hospitals that have the same chart for the levels of normal depending on your age. From age 40 to 50, if you're above a 2.5 PSA, you're abnormal. If from 50 to 60, above 3.5 is abnormal. From 60 to 70, above 4.5 is abnormal. And from 70 to 80, above 5.5 is abnormal. But what's more important than that, than knowing those normalities and abnormal readings, is any sudden or rapid increase in your PSA level, which can still be a normal level, but can be significant for cancer and the need to do follow-up PSA studies or immediately get to a urologist for biopsy. I'm an example. My reading came in 2019 at 4.2. At 4.2 on that 0 to 4.5 scale, it was a high normal. I didn't know my score from the year prior. I told you men don't know their score. I didn't know my score of 2018, but it did have it on my portal. I looked back at it. It was 2.75. My immediate reaction was I went from a 2.75 to a 4.2 in 1 year. What is going on? I called my doctor. He agreed. He said, yeah, don't worry. Don't jump to conclusions. We're going to get you to a urologist. But that's the example. But I could give you another example. I mean, even if last year you were a 1.0 and you're 58 years old, abnormal is above 3.5. You were a 1.0 last year. If you come in this year at a 2.5, you should be talking to your doctor and saying, I'm concerned. I went up from 1 to 2.5 in 1 year. 2.5 is abnormal for a 45-year-old. So it's significant for cancer for a 45-year-old, and the rapid increase should concern you. I think what your doctor would do is say, let's do another PSA test in a couple months, and if there's another rise, they'll be concerned, but at least you've alerted the doctor to it. You've got to be your own self-advocate for monitoring your PSA, because normal is a word that scares me after what I've been through and seen other men go through. You've got to know if there's an increase, that you've got to alert your doctor and act on it. If you're a man who has prostate cancer in your paternal bloodline, you need to tell your doctor you want to start getting a PSA test in your late 30s, early 40s, because you have a high probability of getting it between age 40 and 45. And having prostate cancer as a young man is worse than getting it as an old man because of the aggressiveness of those cancer cells. That's just statistically correct. They have a harder time treating the aggressiveness of the prostate cancer in a young man. So when my PSA came in as abnormal, I went to the urologist. So what is the urologist going to do? He sat me down and started talking to me about cancer. When he started talking to me about cancer, I said, I thought this could be something else. He goes, well, yeah, it could be, but I just want to tell you that if it is cancer, I'll talk to you a little bit about that. And what we're going to do is we're going to go in, I'm going to do a biopsy, do an ultrasound and a biopsy. And then he shows me this sort of gun that I swear was about that big around with plastic on it. And I said, how are you going to check my prostate with that? He said, well, I'm going to go right up your anus and through the rectum, and we're going to look at it. And did the ultrasound, comes out, and he's looking at the ultrasound. Of course, I asked questions. I said, what's going on? What's the size? He goes, normal. I said, so that means I have cancer. He said, no, we still have to do the biopsy. Don't jump to conclusions. So we did the biopsy. First, you go in with that same instrument. There's a needle on it. It's going in through the rectum, into the prostate, inject you with lidocaine to numb the prostate for the biopsy. He goes in then puts the thing back in with his tool to do the snips from the biopsy, the tissue of the prostate for the biopsy. He does the first one. Of course, I felt it. He goes, you're not supposed to feel anything. Let me go in and do another shot of lidocaine. So he goes back in, does another shot. Then he goes back in and does the 16 biopsy tissue samples. We wait for the result. I think it took a couple days, maybe a week. I get the call that I have Gleason 6 prostate cancer. The Gleason score meant nothing to me then. I have a hard time understanding it now, but it's a way that they grade and stage the cancer cells they see under the microscope. They are graded from Gleason 6 to Gleason 10. Gleason 6 is an indolent, low-risk, non-aggressive form of prostate cancer. Once you get to 7, it's intermediate risk. 8, 9, and 10 get to high, into the higher and highest risk. When you're at 7, 8, or 9, or 10, you're going to be going to the doctor to either be treated with radiation or prostatectomy to take care of the cancer that's in your prostate. My recommendation, based on my experience, the story I'm going to tell you next, is if you're a Gleason 6 and that prostate's going to come out eventually, take it out as soon as possible. What the doctor offered me, because I had a low risk cancer at age 58, was we could watch it. Some call it watchful waiting, but they call it more often active surveillance. He told me the risk of the surgery are erectile dysfunction, incontinence, and then the normal risk of any surgery when you go under general anesthesia, infection, all the way through death. They have to give you all the risk. The main ones you hear as a man is ED, incontinence, and the surgery can wait. Music to your ears. That's what I did. So the active surveillance was come back in 6 months for another biopsy. I went back, I made the appointment in June of 2020 for the next biopsy. I got a call on the day of the biopsy that the surgeon was still in surgery and could not see me that day. We need to reschedule. So I told him, I can come back tomorrow. I can come out there next week. I'm free. When do you want to do it? They said, no. On his schedule, he can't see you till August 6th of 2020. So I thought it was supposed to be 6 months. He's not worried about it. We'll do it in August. I go back in, do the biopsy, get the results. Gleason 7 intermediate risk cancer. He as the surgeon, says, you need to take the prostate out. We need to schedule you for prostatectomy. Because we had just done the biopsy, you've got to wait 60 days before we'll do the surgery because it's so inflamed. And by the way, one of the things I told you about the prostate, that has this fluid, this seminal fluid that gets pushed into the urethra by the prostate when you ejaculate for the sperm to go down to the reproductive. One thing I failed to mention was that after your biopsy, and now I've hit 2 of them, the doctor told me, and I hear other men say that the doctor doesn't tell them, so I'm telling you so you know, that that fluid is going to be filled with blood because that prostate is bleeding after the biopsy for about 4 to 6 weeks. So he said, feel free to have sex. There's no problem with that, except for the fact when you ejaculate, you're going to be ejaculating blood. So I'm just warning you, and I'm telling you that that does happen, for sure. So after that second biopsy, I get the result that it's Gleason 7 and that I have to do a prostatectomy, or I have an option of doing radiation. Radiation therapy can be done, and you can keep the prostate. A radiation oncologist will usually put seeds within the prostate that are radioactive to fight the cancer within the prostate. You might also need to do external beam radiation, but the prostate stays in. The surgeons and the radiation people will argue about which one is better. The end result is the result for the patient is usually about the same, but there are pros and cons to each, and there's psychologically, I think, a pro to taking the cancer out of your body, which is what I chose. I wanted the whole prostate to come out with the cancer, and I wanted it to be done. So I scheduled the surgery. For November 6, 2020, I had the surgery. Before the surgery, the doctor said, we'll be out of here in 2.5 hours. I said, what about the nerves? Don't forget to spare the nerves. I want to make sure that you take those out and or take those aside and you protect my erections. He said, no problem. I have the highest success rate on that. We're doing the Da Vinci robotic surgery. There will be 4 holes along in your abdomen, and then there will be a incision at the top of your umbilical where the prostate will come out. The robot is the main way that they are doing prostatectomies now through this Da Vinci robot. Open procedure is still done by many surgeons, especially guys that have been doing it for so many years and didn't ever take on the training for the robot. And they're still doing very successful surgeries, but right now most prostatectomies are being done by this Da Vinci robot, by a skilled surgeon operating the robot to take it out. And because it is so good, they are having a lower incidence of erectile dysfunction and incontinence as a result. So I did the surgery. I came out of the surgery and was in my room when the doctor came in. He asked me how I was feeling. I said, good. I was kind of surprised it was dark since my surgery started in the morning. He goes, well, yeah, your surgery took 5.5 hours. You are what I would call a bleeder. I couldn't stop your bleeding. You just kept bleeding. He said the nerve on the left side was stuck to your prostate. I had a hard time pulling it off the prostate and lifting it free of the prostate. The other side was fine. That nerve should be fine. He said, in addition, I found a tumor in one of the first lymph nodes that I took out. When they do the prostatectomy, they resect some lymph nodes to check for cancer in those lymph nodes, because oftentimes if the cancer gets out, it will first go into the nearby lymph nodes, so they check them. When he found the tumor, he said, I took out 19 of your lymph nodes, so we have a good selection for the lab. Prostate and the lymph nodes went to the lab and came back as prostate cancer, had metastasized to the lymph node, and the prostate had what you don't want to hear from your surgeon is had a margin. Margin means it has a crack, a hole, a fissure, whatever medical term you want to use, but it's an opening. The wall has broken and the cancer has escaped the prostate. And when I'm talking about the cancer has escaped, It's not like just a few little cells got out and we're going to go find them. Millions of prostate cancer cells leave the prostate and get out into the body and are now looking for new places to spread and form new tumors. After the prostatectomy, when you go home, you will have a catheter to drain the urine from your bladder. And the reason for that is when they take out the prostate, they have to cut the urethra, which is attached to the bladder neck of the bladder. That internal urethral sphincter is cut and taken away with the prostate. The lower external sphincter is preserved, and the part of the urethra that is preserved at the external sphincter is pulled up and attached to the bladder neck and sewed on to the bladder neck. So now you have one sphincter instead of two. And that attachment, which is surgically, sewed on, has to heal. And they've determined that takes about 1 week. So for 1 week, you have to have a catheter to allow those sutures for that bond to take place between the urethra and the bladder. And then when they pull the catheter out, you should have your normal urine flow. After a prostatectomy, any prostatectomy, a man will experience erectile dysfunction for 12 to 18 months. Some men, the lucky ones, it's 3 to 6 months. But for everybody, you should expect that you will have ED for a good 12 to 18 months. They're highly successful with the way they're able to lift the nerve in the robotic surgery to you having full erection come back. But because you will not be having an erection for 12 to 18 months, your doctor will put you on, right now it seems the drug of choice is Cialis, or its generic tadalafil. They also use Viagra. But those drugs, what they do is they increase your nitric oxide so that you can have more blood go into the penis to create an erection. It won't be creating an erection, but it will bring blood into your penis and keep the tissues healthy for future erections. And that's very important, to keep those penile tissues healthy, to protect the possibility for your erection. A lot of men ask me, and I'll tell you right now, they say, what about orgasm after prostatectomy? What happens to that? Especially if the nerve is injured. Interesting thing about that is those erectile nerves have nothing to do with your orgasm. They only have to do with your erection. If you're sexually aroused, you can have an orgasm, but a partial erection you certainly can, or an erection that can't penetrate, you still can have an orgasm, because your orgasms are controlled by your autonomic nervous system, the sympathetic and parasympathetic nervous system, which is your brain and your spinal cord. So when you feel the arousal, the brain kicks into the spinal cord, you will have an orgasm. But all of the vesicles for the fluid, the prostate, the seminal vesicles, are all gone. So that will be a dry orgasm for the rest of your life after prostatectomy. What does it feel like? I've listened to a lot of doctors talk about men's reports on it. I have my own personal report on it, but I will say that it is, for most, it's the exact same as it was in a regular orgasm. For some, it's not as good. For some, they claim it's better. I'll leave it at that.
So for urinary incontinence post-prostatectomy, which is a risk, and most men experience it for a few months to a year after surgery, the best way to avoid urinary incontinence is something I'm going to tell you about that you men will think is something only women do, because they are trained to do this when they have babies for their potential urinary incontinence. Kegel exercises. Kegel exercises are for men too. We should be proud about doing Kegel exercises. You need to have a strong pelvic floor so that that sphincter controlling your urine flow is strong, and you will not have incontinence as a result. I'm not going to tell you how to do Kegel exercises. There are books on it. There are books actually out there called Kegel Exercises for Men. If you go on the internet, you'll find demonstrations of how to do various Kegel exercises. I will tell you that in yoga classes, Pilates classes, and a power plate, even with your personal trainer doing floor exercises, they know how to strengthen the pelvic floor. If you do not get prostate cancer, you still should be doing Kegel exercises, because when you get into your older years, you'll be thanking me for this video when I told you in your 50s to start doing Kegel exercises, and you will not be buying diapers and pads in your 70s and 80s.
For me, after we found out that I had metastatic disease, the treatment choice was going to be radiation of the area of where the cancer cells are located, and hormonal therapy. Hormonal therapy, also commonly known now as ADT, androgen deprivation therapy. The androgen is your testosterone. We all know what deprivation means. They're going to take it away. I just want to tell you that androgen deprivation therapy used to be called chemical castration. I don't know why they changed it, because that's what it is. They give you a shot that strips you of your testosterone. For me, they wanted me to be testosterone free for 18 months. The first shot that I had was in October. And I have to take you back to why it was in October of 2021 when my surgery was in November of 2020. You know, we found that I had metastatic disease in early 2021. So the question was, how and when are we going to treat? The local doctors wanted to go right in and radiate my pelvic floor. And I questioned them, is that where the tumor is? They said, we don't know, but we think that's where it probably is. I was very uncomfortable with that. At that time, somewhere in 2018 through 2020, a new technology was developed in the prostate cancer research arena of a PSMA scan. PSMA is the prostate-specific membrane antigen. On a prostate cell, there is a membrane. These doctors who are so smart figured out that this membrane would soak up radioactive material and allow it to light up on a scan, on a PET scan, so that they could specifically find prostate cancer tumors. When I was diagnosed in 2021, I had the diagnosis and I had to make a decision what I was going to do. There were only 3 hospitals in the country that had the PSMA scan. One of them was University of California, San Francisco. There was another one in California, I can't remember, it might have been UCLA, but I don't remember. And I don't remember where the third one was, because I called University of California, San Francisco after having this conversation about how they were going to radiate me without knowing where the tumor was. They said I could come there when I got to a 0.5 PSA. That's when they would put me on the scan. I said, I had told my wife that that's what I was going to do. We're going to go out to California when it might get to a 0.5. Then the sort of miracle happened. I had this guardian angel friend who had gone through the treatment that was being offered to me about we're going to radiate the pelvic floor, not knowing where the tumor was. And then with him, they had him on the hormone therapy. Then when he went off the hormone therapy, his PSA came back. Then they put him back on the hormone therapy. Then his PSA came back when they took him off. And that went on for 10 years until he found Dr. Eugene Kwan at the Mayo Clinic, who did a scan on him, not a PSMA scan at the time because it wasn't available, but a different scan, and said the problem that you're having is the tumors were not in the pelvic floor. They radiated your pelvic floor. You have a tumor in your back, and we're going to go in and take care of those. And he said, so my friend said, so Joe, so this doesn't happen to you, I'm going to have Dr. Kwan call you. I literally got off the phone with University of California, San Francisco, and my phone rang. Joe, this is Eugene Kwan, Mayo Clinic. I said, I can't believe you're calling. I said, I just met with the radiation oncologist. And he goes, oh, don't tell me what they said. He goes, I know what they said. They told you they're going to carpet bomb the pelvic floor. They don't know where the tumor is. And they want you to start hormone therapy this week. I said, exactly. He goes, you're not going to do that. And I said, okay, well, what are we going to do? He goes, I won't treat a tumor till I find the tumor. I've got scans here that will be able to find the tumor. I said, I literally just talked to University of California, San Francisco. They have the PSMA scan. I'm sure you're familiar with it. He goes, not only am I familiar with it, we were now, this week, we were just the fourth hospital in the country to be approved for that scan, and we'll have it here in about 4 weeks. I'm going to put you on the scan when you hit a 0.25 PSA. I said, why 0.25 when they're doing 0.5 in California? He said, I think we can find it quicker. I think we can find it at an earlier stage, and I'm going to run a clinical study to see if we can find it 0.25, and you, in fact, will be one of my first guinea pigs. He said, you're going to have to take a leap of faith right now. You're going to have to let your cancer grow until you get to a 0.25. You're already talking about wait until it got to a 0.5. Just let it grow until it gets to a 0.25. Then you're going to call me. I'm going to put you on the scan. So that's what we did. I waited. It crept up over time throughout 2021. Toward the fall of 2021, I think it was September or October, I had hit 0.21. I knew I was getting close, so I did another one. About a month later, it was 0.34. I went to Mayo Clinic. They did the PSMA scan, and they found the tumor. The tumor was sitting in the seminal vesicle bed in the pelvic floor, but now we know where it is. And now they could do radiation that was very targeted. So Dr. Kwan, when he saw the scan, he said, the size of your tumor is the size of my pinky fingernail. And he said, I want to congratulate you. I said, well, you can congratulate me for having a prostate cancer tumor. And he said, because I have over 8,000 patients that I'm treating for metastatic prostate cancer, and you have the smallest tumor that I've ever treated. And that's because we found it on this scan at this low PSA level. So this is a very good thing happening in prostate cancer world right now, is to have diagnostic tool like this where they can find cancer earlier. After the scan was done, he said, first thing we're going to do is put you on the hormone therapy. You might be wondering how about these prostate cancer. There's these PSA readings, and why would there be PSA reading? If your prostate's out, I've been asked, if your prostate's out, why would you have a PSA reading? You don't have a prostate. Because remember, millions of prostate cancer cells got out, and those prostate cancer cells are putting out PSA scores. So that's what we were looking for when we got to the 0.34, and then we did the scan. After the scan, now it was time to do the chemical castration, the androgen deprivation therapy shot. That day, they had already done my testosterone. I was at 717. We're going to do the shot. In a few days to a week, went down to 0. Because prostate cancer cells feed on testosterone for nourishment and growth, and frankly to thrive, that was a process that I was going to be undergoing. Every 3 months, I was going to do a shot to keep my testosterone at 0 so that the cancer cells will go to sleep. They go into a state of senescence, which means they're just sleeping or slowed down. And then the radiation oncologist would draw out an area after looking at the MRI scan and the PET scan they did, the PSMA scan, to figure out where they want to radiate to protect the bladder, the kidneys, all the local organs nearby. And then they specifically know where the tumor was. So for 8 weeks of radiation, they're going to do different levels of radiation. But for the last 2 weeks, they're going to move from radiating the entire area, including the tumor, to focusing on the tumor itself, which was that small little fingernail tumor, the pinky fingernail tumor. They're going to focus on it to kill it. The doctor, the radiation oncologist, would tell me beforehand, he said, during the radiation, what you should expect is you're going to get very weak, you're going to get tired. You also will probably get nausea, especially the second 4-week period. It should go fine at first. I said, what can I do to fight it? He said, there's really nothing, except a lot of people say that if they go for walks and keep active, which is hard to do because you'll be very tired and you'll feel weak, then that helps. So, of course, what I did was I joined the Rochester Athletic Club, and I signed up for 3 weightlifting classes a week, and I brought my eight-month-old puppy with me to Rochester. She's a big dog, and she needed training, and she needed a lot of walks. So during the period of February through March, that cold weather, I was walking my puppy a lot. I was going to workouts, and every time I went each week to the radiation oncologist, he'd say, "How are you feeling?" I said, "I'm fine. I don't feel anything." So he was amazed, and he said, "Whatever you're doing, keep doing it." So my recommendation to anybody going through this radiation is exercise, and as much as you possibly can. I think it helps. So the androgen deprivation therapy is, I think, I wouldn't wish this on my worst enemy, although it is so important that you have it to make sure those cancer cells are asleep to be radiated. But to have it go on for 18 months of shots, and for me, the zero testosterone lasted 2 years. I put a chart here of the side effects of ADT. Loss of your sex drive, libido, erectile dysfunction, bone density loss is a possible side effect, bone fractures are a possible side effect, weight gain, muscle loss, loss of muscle strength, hot flashes, gynecomastia, very fancy name for growing breast tissue. There are many more. The ones that I experienced, I know one that I forgot that was very important that I experienced, is metabolic disorder and insulin resistance. I'll start by talking about the hot flashes. All the women in the audience, especially those who've gone through menopause and those who've been with them, know what hot flashes are. For the men, that's something you think that's what they have. I will tell you, the reason women go through hot flashes is because when they go through menopause, their estrogen decreases to the point that they go into a complete hormonal imbalance. And their vasomotor reaction is these hot flashes. As a man, taking your testosterone down to 0, guess what it causes? A complete hormonal imbalance. And you have hot flashes. And I had 5 to 10 hot flashes a day. At a minimum, 5 every day. Oftentimes 10, sometimes more. So I'm just saying 5 to 10. I could describe it as if you ever held your hand on the hot water heater after the pilot light went on and you heard it light up and you could feel that the water is getting hot, that's sort of like the hot flash. You feel like somebody lit a pilot light and all of a sudden you start getting a little bit hot, then you start getting real hot. I'm pointing at my shoulders because it started there, would go up into my head. I would be sweating, forehead, down my face. My hair would get soaked, my underarms soaked, my shirt soaked. Now this could happen. I'd be sitting at a restaurant talking to one of you, and all of a sudden you'd be like, what the heck's going on with him? He's sweating like crazy. You have to tell people I'm having a hot flash. I had them mostly at night during sleeping. So, you start getting this hot flash, you kick off the covers, can't stand to be out of the covers, you get into a full sweat, the pillow is wet. And then of course, then it stops after about 5 minutes, and now you've perspired and you're wet, laying in bed, and it's winter, and then you start getting cold. So now you want to get warm, and you got a wet pillow. So they say that you get fatigued because of your zero testosterone, but I think that the reason you have fatigue is because of all these nighttime hot flashes that you have, and it's almost impossible to sleep. Weight gain is another side effect. At first, it was like 10 to 15 pounds I seemed to be holding there. That was throughout 2022 into 2023. And then I started feeling the effects of one of the other side effects, metabolic disorder. I was noticing I'm also a type 1 diabetic in addition to having prostate cancer. I've been a type 1 diabetic since age 35. Type 1 is where your pancreas does not produce insulin. So I inject my own insulin. I have a continuous glucose monitor on. My blood sugars were almost impossible to control. I was using 5 times the amount of insulin to keep my blood glucose normal. One of the other things in metabolic disorder that you experience is lipid your lipids go out of control. In other words, your cholesterol rises. My LDL was rising. My triglycerides were rising. It was a mess. All of that insulin resistant also led to a faster, more rapid weight gain, to the point where at one point I gained 50 pounds. At the end, it was 45 to 50 pounds. As I was gaining this weight, I tried multiple diets. I tried keto for several weeks, and I'd done that in my past. And when I would try keto in the past, I would lose like 10 pounds in the first 2 weeks. Instead, on keto, I was not losing weight, I was still gaining weight. I tried to stop drinking. I tried to cut back on my food. It got so frustrating that I finally just said, I'm just going to live life and deal with the weight when I'm done with the testosterone depletion. During my workouts at the gym, I would hate the mirrors more than anything else at the gym, because I'd watch myself, I'm getting fatter, and then I also had muscle loss and weakness, which is another side effect. I literally could see that my muscles were getting smaller, I was getting fatter, and my trainer was handing me lighter weights to work out with, but we just kept doing it, and we got, I wanted to keep maintaining strength. One of the other side effects I had from the ADT, which was an unusual one, the doctors had never heard of it, most had not heard of it, was my hands got completely inflamed, they were swollen, I couldn't get my ring off. At one point my doctor tried the steroid shots, and the steroid shots reduced the swelling a little bit so I could take my ring off. I lived without my wedding ring for 10 months. I could not do this. I could not put my thumb to my little finger to put 3 fingers up. That was impossible. I looked at all this research online. I found one article in a medical journal from a research study in Japan, where this doctor had found a whole bunch of men who had these exact symptoms who were on ADT. And his conclusion was that doctors need to explain this risk to their patients so they're not surprised when they have it. My last shot of the drug was called Eligard. It started with Lupron, then it went to Eligard, but it was my last ADT shot was in February of 2023. That shot lasts 90 days, so it would wear off in May of 2023. Of course, I thought when this wears off, my testosterone is going to come right back. Of course it will. So I did a testosterone test a month later. My testosterone was at 10. It wasn't 0. My doctor said, well, we'll do another one, and did another one. It was at 0. So I wasn't happy about this. He said, okay, now let's just wait. Let's do the next one in July of 2023. I did end of July, I did a test. I was at 8. My testosterone was at 8. Not 0, but 8. We're going to do the next one in October, 3 months later. A woman's normal testosterone level, some men here don't even know that women have testosterone. Women know that. And you probably don't know that you have estrogen. Men have estrogen and testosterone. We have more testosterone than estrogen. They have more estrogen than testosterone. But a woman's normal is 30 to 90. I'm at 8. When I did my October test, my hope was that I could be a woman. I just wanted to get from somewhere between 30 and 90. When that result came in, it was time to open the envelope, so to speak, and see the result. It was one of the happiest days of my life. I opened it up, 377. Since October of 2023, testosterone level has continued. It went into the 400s, the high 400s. And then in February of this year, I hit 767. And then in May, just last month of 2025, I hit 572. So it seems that I'm in that area where I might be floating around 600, which is good for my age group. But here's why why I'm telling you so much about the testosterone rise, is because at the same time, your PSA should be non-detectable when you're on the drug, because they've stripped you of your your testosterone, so the prostate cancer cells don't have anything to feed on, so your PSA should be non-detectable, and it was. In fact, if the PSA is detectable when you're on the ADT, then you have something that they call, and this is sort of a horrible diagnosis, you have what they call castration-resistant recurrent prostate cancer, and that requires a whole different level of aggressive treatment. You don't want to have that. So when the testosterone came back in October of 2023, of course, then the fear is the PSA going to come back? Are the cancer cells going to wake up? PSA every 3 months since October 2023 has been non-detectable, even this May, non-detectable. So in the face of rising testosterone, PSA has been non-detectable. I consider that to be a very positive sign. So in the end, why do you want to get your prostate out when you get diagnosed early? Because you don't want to go through all this metastatic disease and treatment. The biggest mistake I made was listening to active surveillance and agreeing that might be something I like to do. The way I look at active surveillance now is the only thing that's active is the cancer. And you've got to remember that you have an active growing cancer in the prostate. You're better off taking the prostate out sooner rather than putting it off for later, because if it breaks through the wall, you end up with metastatic disease. I think of it now, I knew I was going to take the prostate out. I was just waiting to see, not necessarily at 6, but at some point in my life, it's going to come out. I have prostate cancer. He's just telling me it's going to grow real slow. The surgery could be delayed, maybe a year, maybe 2 years, maybe even 5 years. In my mind, I'm thinking, okay, the prostate's going to come out. I'd rather wait. That was the mistake I made, was saying I'd rather wait. If it's going to come out, and you know it's going to come out, you've got cancer in the prostate, take it out. The doctors are amazing at all the research hospitals, Mayo Clinic, MD Anderson, Dana-Farber, Northwestern, you name it. There's so many hospitals that are doing so many great things for life-prolonging treatment. Men are living with metastatic disease their full life expectancy, but they have to have a lot of treatment, medical treatment. The thing about prostate cancer is that our metastatic prostate cancer, it is still considered today an incurable disease. But the question is, with all the great work these doctors are doing, is will they find a cure through immunology or through their radiotherapy treatments, through all the chemo that they're doing to prolong life? Will they continue to learn how cancer grows and how we can kill it and cure it for good? If there's one takeaway from this talk, is you need to know your PSA number. Be on top of it. Watch for any increases from one test to the next, even if it's told to you that it's normal. If there's an increase, be concerned, stay on it. Another takeaway for the women in the audience. I already talked about how men do not want to talk about this, but now you have the knowledge about prostate cancer, early diagnosis and treatment. Please, please share this information with your loved ones.